Welcome to this series of educational modules titled Mechanical Circulatory Support, Bringing Clarity, the Why, When and Who. My name is Professor Simon Redwood and I'm an interventional cardiologist at St Thomas's Hospital in London, and I'll be introducing and chairing these sessions. The main purpose of this session is that it is well known that the balloon pump is the first choice for mechanical circulatory support for cardiologists throughout the world. However, their appropriate balloon pump therapy has been subject to very heavy debate. Importantly, there appears to be a dichotomy between the clinical trial results and real-world practice. And the purpose of this series is to present a review of the physiological principles behind mechanical circulatory support and discuss the dichotomy between trial results and real-world practice and how that should reflect on patient selection. Welcome to this module titled The Critical Science, Understanding the ABCs of Mechanical Circulatory Support. I'm joined today by Dr. Divakar Pereira, who is a colleague at St Thomas's Hospital in London and an interventional cardiologist who will be presenting this module. Divakar.
Thank you, Simon. I think it would be helpful to start with defining the goals of circulatory support, whatever strategy that might be used, and I've gone through this in an ABC format. So the first goal of circulatory support, certainly from a cardiologist's perspective, is myocardial protection. And in a sense, we're talking about maximizing our chances of overcoming ischemia. And as we know, ischemia is a matter of balance between supply and demand. Myocardial oxygen demand, in turn, is determined by heart rate, contractility, and afterload, whereas supply is determined, in addition to coronary patency, by the microvascular function or microvascular resistance and your diastolic pressure time integral. And the different circulatory strategies will affect this balance or imbalance differently. So that's the first goal, myocardial protection, because through myocardial protection, we can maximize the chances of myocardial recovery, for example, following an ischemic insult. Goal B is to improve or optimize organ perfusion. And I think it's worth us spending a little bit of time thinking about the physiology of organ perfusion. So the end goal is to maximize tissue blood flow. And we often think of mean aortic pressure as being the main determinant of tissue blood flow. But it's important for us to remember that it's not only decided or determined by aortic pressure, but also by tissue vascular resistance. Now, many of the techniques and approaches we have to increasing aortic pressure rely on increasing peripheral vascular resistance. And alongside peripheral vascular resistance, tissue vascular resistance will also be increased. So if you increase your peripheral vascular resistance and augment your pressure, you may also be increasing your tissue vascular resistance and therefore counteracting any effect of the change in pressure.
So you think we just get falsely reassured?
We do. We see the numbers, we get reassured by the blood pressure being elevated, but it may not necessarily translate to tissue level perfusion improvements. Sure. And in addition to mean aortic pressure, of course, the goal is to improve cardiac output. Now, cardiac output is determined by a variety of factors. We all know that it's a product of stroke volume and heart rate, and stroke volume in turn depends on end diastolic and end systolic volumes. The end systolic volumes are affected by contractility and afterload, whereas the end diastolic volumes are driven by filling pressures and cardiac compliance. Now, all of the different strategies we have available to us will affect each of these parameters differently. And it's important to try and appreciate and understand where your patient is and how you would like to affect each of these compartments when deciding which strategy we ought to go with. C, and the third main goal and main issue with deciding on strategies, how safe is it? And how easy is it to use? In terms of safety, really we're thinking about bleeding and vascular access site complications when you're talking about mechanical circulatory support, and also cerebrovascular complications, bleeding and embolic events. But alongside that, we've got to think about how readily available these strategies might be. Is it going to be available on any cardiac unit, or is it only in specialist units that it will be available? How quickly could we initiate these therapies? And also, what degree of specialist expertise is required to both initiate and then monitor and manage these therapies? And I think these are all important considerations in deciding which strategy. So what I'd like to now do is to go through the different available strategies and consider them through this ABC sieve that I've set out. Well, let's start with inotropic drugs, because most of us are familiar with inotropes. They've been around for a long time, and they are actually the first go-to if you've got a patient in trouble. This slide shows a schematic representation of the different targets, the cellular targets of inotropic drugs, and I won't go into that in much detail. But the table you see on the next slide summarizes the effects of the different inotropic agents on each of those hemodynamic parameters we have discussed: cardiac output, systemic vascular resistance, mean arterial pressure, and tissue-level vascular resistance. And what you will see is that all of these agents aim to improve cardiac output, and by and large they do, but all of them do so at the cost of increasing myocardial oxygen demand. They have varying effects on tissue-level vascular resistance. Epinephrine and norepinephrine increase tissue vascular resistance, and that's perhaps one of the main mechanisms by which they increase mean arterial pressure. So while all of them have beneficial effects in terms of increasing cardiac output, the real drawback is that they come at a cost. The cost is increased myocardial oxygen demand. And in many of these cases, increased tissue vascular resistance as well. So you don't really get organ perfusion.
So although they're first-line agents in many centres, do you think we should be very cautious in their use and very limited in their use?
I think they have a definite role because of the ease of use, and the fact that we can start them rapidly. They really can bail you out if your patient is very ill, because they give you stability until you can deliver a more definitive therapy. So I think they do have a role, but continued reliance on them for a prolonged period of time, in my view, is not the way forward because of these costs that we've spoken about. And a strategy of keeping a patient on inotropic support until they really are very unwell and then considering mechanical support, I think is probably too late. And identifying that time where you'd really need to think about a better assist strategy which has less costs and more benefits associated with it. I think that's the key, and that's hopefully what we'll get out of this module. The next strategy that I'd like to talk about is the intra-aortic balloon pump. As you said, Simon, we've been using, or the medical profession has been using intra-aortic balloon pumps for nearly 5 decades. But perhaps the science of counterpulsation has been forgotten or glossed over, and I'm going to spend a few minutes talking about just how a balloon pump works. So by inflating in diastole, and that's an ECG-triggered mechanism, the balloon pump is able to augment aortic pressure during diastole. That most people know about, and that is what most individuals think is the mechanism of action. But a forgotten second mode of action is that by deflating at the end of diastole, there's a reduction in end diastolic pressure or early systolic pressure, and that translates to a reduction in afterload. And if you like, those two different mechanisms of action can be thought of as the effect of balloon counterpulsation on supply and demand. By augmenting diastolic pressure, or the diastolic pressure time index, supply is improved, and by decreasing end diastolic pressure, decreasing the tension time index, if you like, demand is reduced. So we've got a device that has the potential to improve supply and simultaneously decrease demand, which is in stark contrast to the inotropes.
Sure. So it has beneficial effects on both sides of that balance.
On both sides of that balance, absolutely. But is it really that simple? Does an increase in pressure automatically translate to an increase in coronary flow. Now, we know that the coronary circulation is governed by a principle called autoregulation. In other words, coronary flow will be maintained at a constant level despite changes in perfusion pressure for a given myocardial oxygen consumption. Now, that's meant to protect us against drops in blood pressure, but does the reverse apply? Does the heart resist an increase in pressure and maintain flow at a constant level? Now, this sounds outrageous, but as you know, this is something we have studied recently by looking at a small cohort of patients undergoing high-risk PCI. And in this experimental setup, we modulated autoregulation pharmacologically by using adenosine. So we were able to give these patients intracoronary adenosine and temporarily disable the autoregulation. And this gave us some interesting insights. And it shows that the heart does have the ability to autoregulate even against increases in pressure. So although diastolic pressure is increased by the balloon pump, the heart responds to that by increasing microvascular resistance. And that's the top slide on the right of this graph. And the lower slide shows that the velocity time integral, which is a surrogate of flow, actually doesn't change at all.
So are you saying that if, assuming my autoregulation is working, if you put a balloon pump into me, it would have no effect on my coronary flow?
That's right. I mean, our data suggests that it'll have minimal effect, if any, on your coronary flow, although the diastolic pressure will be increased if you are healthy and well at the time.
So maybe this, and this is something we'll come back to when we discuss the other module in depth, but maybe this is one of the reasons why some of the clinical trial results seem to be a dichotomy with our clinical practice.
It certainly seems appealing to apply this new information to try and understand the results of the clinical trials, and it may explain just that. Now, if you were to disable autoregulation, and I now moved on to my next slide, which shows some representative traces, you see an entirely different picture. Now, you see three panels of data here: the ECG, which provides the IABP trigger; the pressure trace, which is familiar to most of us because this is what we see on our IABP console; and then the bottom panel is a flow trace, and this is something some of our viewers may not be familiar with. This is a representation of the balloon pump working in a 2-to-1 augmentation mode. So each pair of curves shows augmented pressure and then unassisted pressure. And what we'll see is that when autoregulation is disabled, all those increases in pressure translate directly to an improvement in coronary flow and therefore myocardial perfusion.
And it looks like quite a dramatic increase in flow as well.
It is a very dramatic increase. In this case, we were using a Mega 50 device, and we saw dramatic increases in flow in the assisted mode compared to unassisted when your autoregulation was disabled. Pharmacologically in this case, but you might think that this is a situation that would apply if a patient were in cardiogenic shock, or if a patient were to have persistent ischemia following PCI for an ST elevation myocardial infarction, where the conditions where your autoregulation is either exhausted or somehow disrupted.
Sure.
So if we go back to our ABC, which we set out as the standard by which we should judge each of these devices, myocardial protection is certainly provided by the balloon pump because it both improves myocardial perfusion and simultaneously reduces oxygen demand. And what we've seen is that this is probably most relevant and pertinent when autoregulation is dysfunctional or exhausted. So it certainly achieves A. B, well, there's no direct effect on organ perfusion, but of course, by optimizing your supply-demand balance for the myocardium, eventually you'd expect an improvement in cardiac output and therefore an indirect effect on organ perfusion by improved cardiac output.
And it has been shown, hasn't it, that the balloon pump does have a modest effect on improving cardiac output?
It has a modest effect on improving cardiac output, but perhaps isn't its central mode of action.
Sure.
And C was whether these strategies are safe and easy to use. Well, we know it's easy to use because most cath labs are very familiar with balloon pumps. It can be instituted directly. But safety. Now, what I've shown you here is a table summarizing the randomized trial data, large randomized trials. We've only included trials that have had 100 patients enrolled at least, across all of the indications. So high-risk PCI, acute myocardial infarction in the absence of shock, and then AMI complicated by shock. This is a busy table with a lot of data in it, but what I would like to concentrate on are the two right-hand columns, bleeding rates and vascular complications. And you see that across all of these indications in a clinical trial setting, there really wasn't any significant increase in bleeding or vascular complications. And this is particularly relevant to the AMI context, whether in the context of shock, as represented by the IABP Shock 2 trial, or in hemodynamically stable patients, as represented by the CRISP AMI trial. There really wasn't any difference in either bleeding or vascular complication rates compared to patients who had PCI without any mechanical
So this
assist at all.
perception of increased risk with balloon pumps is really just historical, isn't it? From the days of cut downs.
I think so. I mean, the vascular access has become easier as the devices have become smaller and smaller, and I really don't think that is a concern. Safety isn't a concern with this device, and nor is the rapidity of initiation of counterpulsation. If you move on to some of the other strategies, the Impeller Recover pump is an intracorporeal pump, so a pump that is inserted on the end of a pigtail catheter directly into the left ventricle. And this provides direct left ventricular unloading, and it's non-pulsatile flow that's achieved. So left ventricle to aortic flow. And there are a variety of devices in use at the moment, a 2.5 litre, the CP device, which provides about 3.5 litres of additional flow, and a 5 litre device. And as you go up these devices and they become more powerful, so too does the size of the device, and therefore the size of vascular access. So the CP device, which I suppose is the most commonly used, requires 14 French access, and the 5 litre 22 French access. How does it stack up against the balloon pump? And this is a meta-analysis that was carried out a few years ago now and was published in the European Heart Journal in 2009. This meta-analysis included 100 patients, and they firstly looked at the hemodynamic indices and compared IABP with all of these percutaneous assist devices, so Impeller as well as Tandem Heart, which we'll come to in a minute. And what you'll see is that if you look at cardiac index or mean arterial pressure, for example, those more powerful devices seem to achieve it better than the balloon pump. But as we said already, that's not the central mechanism of action of a balloon pump anyway. And wedge pressure drops correspondingly. But this comes at a cost. And the cost in this study was the incidence of leg ischemia and bleeding complications. Because of the wider bore access, there are of course more complications, and this needs to be borne in mind. So let's apply the ABC sieve to Impeller Recover. Myocardial protection. Well, yes, it does achieve myocardial protection because there's a decrease in afterload and there's a clear decrease in oxygen demand. As yet, we don't really know what the effects are on coronary flow and myocardial perfusion, and this is obviously the subject of ongoing research. It improves cardiac output without increasing local vascular resistance, so therefore it achieves B as well, in that it improves tissue perfusion. It is a relatively safe device with a slightly increased risk of bleeding and vascular complications, and that increased risk of vascular complications is what needs to be borne in mind. Also, while most cath lab teams are now becoming familiar with inserting the Impeller, it is a more complex process and does require slightly more specialist knowledge and experience. And what needs to be remembered with the Impeller is that managing it afterwards is more important, if anything, than inserting it. So
because it actively unloads the ventricle.
Because it actively unloads the ventricle. So that's how Impeller stacks up in our ABC. And finally, I'd like to talk briefly about extracorporeal pumps, so external circulations. And we have two main types of assist strategy that are in use. Tandem heart, which is a left atrial to aortic continuous flow strategy, and veno-arterial ECMO, or extracorporeal membrane oxygenation, which is a right atrial to aortic bypass, if you like. Now, they both are powerful, potent means of improving cardiac output or bypassing the heart, if you like. But in terms of our ABC, and talking about C, the ease of use and safety, these are more invasive procedures. Tandem heart requires a transseptal puncture, and both these techniques require really quite wide bore vascular access, so that's something to be borne in mind. They certainly improve cardiac output and tissue perfusion, but this happens probably at the cost of an increased afterload, and increased afterload will mean there's increased myocardial oxygen demand. So it may be that we're supporting the organs, but reducing the chances of cardiac recovery if it is, for example, an ischemic cardiogenic shock patient that we're treating. And as I said,
so they certainly have their uses, but perhaps in a different group of patients.
Exactly. I think in a selected group of patients. So, to summarize, our different support strategies ought to be assessed against the ABC of myocardial protection, tissue perfusion, and ease of use. And all of them stack up differently. They all have different strengths and weaknesses. And certain devices are more potent at providing myocardial protection, while others are more potent at tissue perfusion, and they vary in terms of their ease of use. So how do we apply all of this physiology and science to our individual patient who's in front of us? We have two strategies. One is to make a broad diagnosis and say this is a patient with AMI, or this is a patient with cardiogenic shock or a high-risk PCI, and therefore this is the strategy we use. Or we need to try and make an attempt at identifying the individual patient's physiology and picking the right device. Now, I know we're going to talk about the randomized trial data in the next module. This slide just summarizes some of that data. And all I will say about this at this stage is that all of the trials of balloon pump therapy versus no balloon pump at all, or balloon pump therapy versus Impeller for high-risk PCI, have failed to reach their primary endpoint. And these are all trials that have included patients on the basis of a broad diagnostic label. So what we know is that using a strategy of applying one circulatory assist method based on a broad diagnostic label can't be recommended. Yeah. And I think that tailored therapy is the way forward. If the main goal in your patient is to provide myocardial protection, we need to choose a device like an IABP that will give them the maximal benefit in terms of the ischemia balance. If it is tissue perfusion, that is organ perfusion, that's the main goal, then you might choose a more invasive device like an Impeller via ECMO, which really excel at providing organ perfusion. And C, in terms of ease of use, if you need to get this therapy instituted as rapidly as you can, that's where inotropes have a role, and the more familiar and easier to use devices like IABP have a role. So I think it depends on the patient and the situation you're in, and also which environment the patient presents to.
So you could start with using inotropes and then step up to other devices.
That's right. I think that's important to be able to escalate quickly.
Sure. Okay, that's great. Thank you very much, Divarkar.
Thank you.
So in summary, in this module, we've discussed the principles and the goals behind mechanical circulatory support. Secondly, we then discussed the different support strategies and how they fit in with these principles. And finally, we discussed tailoring the support strategies for individual patients. Thank you very much for your attention.